Hi, thank you for joining us. I'm your host, Nada Youssef, and you're listening to Health Essentials Podcast by Cleveland Clinic. Today, we're broadcasting from Cleveland Clinic main campus here in Cleveland, Ohio, and we're here with Dr. Linda Bradley. Dr. Bradley is the Vice Chair of Obstetrics, Gynecology, and Women's Health Institute. She's also the Director of Hysteroscopic Services and the Fibroids and Menstrual Disorders Center. Thank you so much for being here today.
Thank you for having me.
Sure thing. And today we're discussing GYN, women's GYN health issues. And please remember, this is for informational purposes only, and it's not intended to replace your own physician's advice. So before we jump into the topic, I'm going to ask you some questions just to get to know you on a personal level.
Okay.
So what is the weirdest thing that you've ever eaten?
The weirdest thing I've ever eaten were frog legs.
Frog legs?
Frog
Okay.
legs.
I heard they taste like chicken.
They taste like chicken, and
Yes.
that's what I thought they were when they put the basket of food in front of me in Mexico, and I'm eating, and the gentleman comes back, the waiter, says, would you like some more frog legs? I'm like, these are frog legs? I did think that they were fried chicken
Would you
legs.
have eaten them if
I
you knew?
probably, it's better for me to not know what I'm eating.
Beforehand.
Because I will try everything as long as I don't know.
Okay, good. Good to know. So how about naming one thing on your bucket list?
One thing, I actually right now would like to get a degree, a formal degree as a chef.
Really?
I'd like to go to a culinary institute
Okay.
or culinary school. There are many in Cleveland and,
Yeah.
and local area. But I love cooking, but I would really, for some reason, just want to have the degree
Yeah.
to make it official.
Oh, interesting.
Yeah.
Favorite dish to cook?
I'm sorry?
What's your favorite dish to cook?
Oh, I love anything Italian.
Anything Italian?
And also Indian.
Okay.
Yeah, so-
Need to come over. So what day in your life would you like to relive again?
That's a great question. I really enjoyed all of my pregnancies. So I could relive all the days, I won't say labor, but moments leading up to the onset. But I just had a great pregnancies for both of my kids.
Wow,
And
that's
felt great, took excellent care of myself,
Wow.
and obviously much younger and had
Yeah.
a good experience.
Good for you. And we can talk about that and keep everybody healthy.
Mm-hmm.
All right. So let's get into discussion. So what is GYN women's health?
So GYN Women's Health really approaches everything that women need to have taken care of as it relates to menstrual cycles, pregnancy, contraception, menopause, female issues with the bladder,
Okay.
pelvic floor as we call it, PMS, mood changes, irritability, sometimes depression. So it really covers everything that an internist usually doesn't take care of.
Okay.
The most common things that people would go to their gynecologist for would be for a pap smear and breast exam. But then sometimes there are more problem-based visits that we'll talk about, which lead women to be seen. But if we looked at what I call the GYN organs, we don't take care of the breast, so that would be by a general surgeon. But uterus, tubes, ovaries, cervix, vagina, vulva, what we call the pelvic basin, those kinds
Sure.
of things. Yeah.
Sure. Okay. Anything that makes a woman a woman. So can we talk about signs and symptoms of these problems that may require medical attention?
Okay.
Besides your pap smear that's normal once a
Right.
year, why else would I go to the doctor?
Well, most of the times we would go to the doctor for preventive care. You know,
Okay.
an ounce of prevention is worth a pound of cure. So
Yes.
there's still some guidelines, even if you're well with no problems, that you should be seen for just some screening things that happen. But other things that might come up would be quality of life issues that are affected by GYN problems. Those could be things, the most common things are periods. How many periods do women have? Between 400 and 500 in their lifetime. And so at some point, when we think of starting our periods at age 11 or 12, having them monthly until age 51 to 58, something will go awry.
Sure.
The period's too long, too heavy, we don't get a period, problems with pain or discomfort, spotting after sex, spotting between periods. So that would drive a patient to be seen. The other might be at the other extreme of life when our periods stop, and some women are bothered by vaginal dryness, hot flashes, night sweats, pain with intercourse, so related to a lack of estrogen.
So that's menopause.
Menopause,
going on?
even
Okay.
pre or perimenopause, there's some
Okay.
hormonal fluctuations that can lead to some discomfort and problems. And really, we look at quality of life. Vaginal problems, what are those? Odor from the vagina, itching, discharge, pain in the vagina, a lot of vulvar itching, lesions like herpes, sexually transmitted diseases such as gonorrhea, syphilis, chlamydia. So we would see those kinds of things. And then lastly, our patients increasingly, I think with the Me Too generation, are coming to gynecologists and being much more proactive, speaking with us about interpersonal relationships with their partner, both whether it's heterosexual or homosexual, the issue of domestic violence, abuse, physical abuse, mental abuse, financial abuse, things like that. And another great part of being a female is our sexuality. And patients may come to us with problems with arousal disorders, decreased libido, lack of interest in intercourse, pain with intercourse, those kinds of things. So GYN doctors really see the gamut of these kinds of conditions. And there are many other things I'm sure we'll get to talk about, but these come to mind right off the bat, the kinds of patients that I would see in the last week or in my career.
Sure. And then when you talk about any kind of abuse that's involved, what do you have to do at that point when you hear something like that? I mean, do you have to get anybody else involved? Is there going to be like a psychologist that you will refer to? What's the next step for that?
So we know that domestic violence is a big problem, and many women in our society and actually worldwide face this problem. So first is to find out if there are problems that are there. So for instance, in our bathrooms, women go to the bathroom and we have a hotline, a pull-off sheet on the back of the door. Sometimes patients will come with their partners, husbands, boyfriends, and really before this became a real big issue, I used to think, oh my God, what a doting partner, a doting husband, there for every visit. But then we start looking at some of the signs of possessiveness and other things that can become a little bit unusual. And so women, if they're in the office with their partner, they may not answer yes to certain questions. So most men are not going to go into a women's bathroom.
Right.
So we have some signs. So in terms of what we do, if we recognize it, we have to talk with the patient about it. We also have social workers. We have the ability sometimes to get in contact with the police if there is actual physical harm that you can see and witness, psychological help, all those kinds of things. So first is to bring awareness and attention. And it's important for physicians to be aware. It's really a sad statement, but I have to be honest and very transparent. It wasn't something that I was taught during residency. It was probably 25 years after I became a physician that we start hearing about this.
Wow.
We're taught how to do a hysterectomy, how to do a tubal ligation, how to take care of patients in terms of prescriptions, but the issue of trauma was really not discussed.
Right.
So we are bringing it up, and more importantly, I think through social media and just awareness, patients are coming to us to discuss that.
Sure.
Yeah.
It's very good to know. So let's talk about why it's important to recognize some of the abnormal symptoms that we talked about early, and to see a physician right away. Why is that very important?
Well, I think, again, prevention is the best thing, and early recognition of disease. So I think as women, we know our bodies. If we just look at some things like menstrual cycles, we know that there should be every 28 to 30 days, last for 3 to 7 days. So a woman that's coming in bleeding for 10 days, 14 days, 50 days, 100 days, that's not normal.
Right.
So we would say that we want women to come in to be diagnosed early. Some patients are afraid to come in because they think we're going to tell them that they have the C word, cancer.
Yeah.
Most of the times it's not cancer. It's something that's so simply treatable, even without surgery. And so basically, it's better to be evaluated. And then as a doctor, we look at all the different causes so that we can come up with a cure, so to speak. So I think when patients hide symptoms, delay diagnosis, if there is something that's not good, like a cancer, it's always better to catch something early than late. So I would say for that, it's important. Quality of life, even period problems. Young girls should not miss school for pain and discomfort, should not miss hobbies, should not miss sports. So once a GYN condition becomes, doesn't have to be life-threatening, but quality of life changes. A bigger problem after children and with aging is incontinence, loss of urine when you cough or sneeze, not being able to hold your urine. So what would that prevent? that would prevent someone from exercising, because some women have problems when they're jogging or running. They can't golf. They're always looking for a bathroom. They want to jump out of a car every 45 minutes to go urinate. They won't go skiing. They might not go camping. So it's not that they're going to die from any of this, but it affects our quality of life. And I think it's so important as women that our GYN issues should just not get in the way of anything.
Right.
And so if there's a change in how we feel, I'll point down there. See a doctor.
Sure.
Don't be afraid.
Sure.
Come in and talk. And I think physicians, both with the history, physical examination, blood testing sometimes, imaging, sometimes with ultrasound, CAT scans, or MRI. I mean, I won't say everybody gets everything,
Right.
but we can focus the workup and the evaluation so that we really target what that woman needs.
Sure.
But suffering, that's something back in the 1800s. We don't need to suffer.
Right.
We have lots of great cures to help women.
And it's important to educate our audience, and I'm so glad you're here to talk about it, because thinking about it, since, we're 11 or 12 or 13, let's say you've always had a heavy period. Let's say you've always had pain. Not knowing what is normal because you've always had it. That's very important to educate yourself.
Right. And there are also some things that you just talked about that run in families. But in the older days, our mothers, grandmothers, great-grandmothers suffered in silence.
Yes.
And so sometimes women will hear, we talked earlier about endometriosis, pain, discomfort, lots of symptoms. Yes. And sometimes it's genetic, or fibroids, again, genetic. And there's some other unusual conditions like von Willebrand's disease that make women hemorrhage, but it runs in families. But just because your mother and grandmother, sister, aunt have it does not mean that you have that condition, but that you couldn't be treated. So I think for me, the take-home message is our GYN health, pelvic health, should never interfere with the quality of life and keeping us from doing things. I did an interview once, or was asked to quote something that's going on in Europe. I don't remember what country, but shouldn't women be given like 5 days off a month as a part of their job benefits because of GYN problems? And I just said, I'm sorry, I do not agree with it. They need to see us, our great department at the Cleveland Clinic, or a doctor. No, you don't need 5 days off or 3. You don't need any days off of a month for period-related issues. And the other end of sort of that end of our life or reproductive life, you shouldn't lose sleep and have insomnia from hot flashes and changing your clothing, and your hair is a mess because you're sweating all the time, and avoiding sex because of pain. I mean, women are living older.
Yes.
And so with that, we now have lots of things. I just gave a lecture, not long ago, and the average, do you know what the average age of death in 1850s was for women?
Probably 40.
43.
Wow.
Okay? So women never got to menopause.
Wow.
The average woman had 15 children, 15 pregnancies, because there wasn't contraception. And so now women, we find that if you're healthy, even with a chronic condition at age 65, but you have hypertension and diabetes, but you take care of yourself, you're going to live another 15 to 20 years. And if you make it to 80, you're likely to make it to 100. So we have sort of the menopause years used to be never.
Right.
Then it became a third of our lives, meaning when our period stopped, but it can be almost up to half of our lives. So we have a whole continuum of things that we now are learning about as doctors that we didn't have to know about because women didn't live to be that long, that old.
Yeah.
And so, we didn't mention bone health. That's another thing that we'll see as we get older with osteoporosis and fractures, things like that. So, I mean, it's all those kinds of things that we think about.
Sure, with the aging. So let's talk about the most common gyno problems that you see in your practice.
I think that the things that we see the most would be related to what I call structural problems with the uterus, the most common being fibroids.
Fibroids?
There's 60 to 80% of women have them, but not everybody has symptoms, probably less than half. Increasingly, we're seeing more women, because of being overweight and obese, with problems with their periods due to PCOS, or polycystic ovarian syndrome. We are also seeing, as with aging, the issues with incontinence and bladder issues, and even sometimes rectal problems. So those would be when I think of things. And I would also say that women are taking better care of themselves. And I just read that the average American woman has 1.8 children in her lifetime. I mean, so our birth rates are going down, but also contraception,
Yes.
especially in women that are under 50. And since we're living longer, contraception also has to continue into our 40s and really all the way into menopause. Last year, I diagnosed a 51-year-old with a pregnancy. She wasn't an IVF patient, wasn't infertility and all of that. So we can get pregnant all the way till we don't have a period for a year. So I just look at that as a big continuum that we need to look at also.
That's very good to know. I want to touch on PCOS because you mentioned it could be due to obesity and the way that we're eating. Can we talk about what is PCOS and why is it related to obesity?
So so PCOS stands for polycystic ovarian syndrome. And basically, symptom-wise, women often don't have regular periods. Sometimes they don't get periods at all, months and months, and even sometimes years and years. Other times, the periods are coming very frequently. It can also have some physical symptoms with really bad acne, sometimes with excess hair growth, facial hair, chest hair, hairy arms. And we would ask, does it run in your family? So everything that I'm saying doesn't mean, if you're Italian and everybody has lots of hair, I wouldn't say you have PCOS. Right. I mean, there are certain cultures that are just women are a little bit hairier.
Sure.
So basically it's acne, it's hair growth, sometimes hair loss, being overweight. We don't always know all of the reasons. There can be problems with the adrenal gland, which makes hormones. It could be a problem with the ovaries itself. But we also know that our weight and what's in our waist, WAIST, our central fat, this stuff is not sleeping. It's not dormant. It's not hibernating. And so when we're overweight, we make a lot of chemicals, these fat cells. And those chemicals are hormones. And those hormones are estrogen, or they're converted into estrogen and some byproducts that can lead to just changes in the menstruation, which then puts women at increased risk of not being able to get pregnant because they don't ovulate regularly. Right. So infertility. We can also see precancer, what we call endometrial hyperplasia, and an earlier onset of uterine cancer. So we do a lot of testing looking for tumors and things like that. Most of the times we don't find it. We check for the thyroid, we check the adrenal glands. I mean, that's important to be thorough, but really the majority of the time we can look at a patient and say, you're over your ideal body weight, and that the fat itself, I don't use that word, but the stuff that we carry in our waistline, our buttocks and our hips really is, I just look at as inflammatory cells that make things go make things go awry.
Okay, awry.
Awry is what I wanted to say, yes.
Okay, so do these disorders, any of them relate to infertility?
Yes, if women are not making an egg every month and getting periods that are what we call ovulation, where you make an egg, that will lead to difficulty getting pregnant.
Okay, so what are some of the tests that you do for women to to evaluate the issues that they may have?
For infertility in general?
For infertility or for some of these disorders that we talked about? I'm sure there's a lot of
there are a lot of things. I think when we look at infertility, I always say it takes two to tango to make a baby. Right. So 60% of the problem may arise within the woman. I should say 50%, about 40% with men, and then 10% both have a problem. Okay. So the issues with women could be age. As we age, our ovarian reserve, the eggs themselves, the quality, the number of eggs change, especially over the age of 35 and over 40. Other causes can be infection that could have caused problems with pelvic inflammatory disease, infection of the tubes, problems with the uterus, such as polyps or fibroids, or there could be some unusual anatomic problems where women have what's called a septum, sort of a malformation within the uterus that may need correction. Those would be the more common things that we look at. So we kind of start from head to toe to think about the pituitary gland, which is our master gland. Is it functioning right? There are tests that we do for that. I won't go through all the details, but we kind of go from head to toe looking at the different organs, the thyroid, the ovaries, the adrenal glands, to sort of put the story together.
Sure.
And then for men, we have to look at a semen analysis. Are there enough sperm? Do they swim fast enough? Are they motile enough? Do they have the right anatomy? So we look at that. And so we kind of look at all of these factors.
Sure.
Also, things can impact infertility. You could be perfectly fine. Smokers, women who smoke, the nicotine's not good for anything, and it often ages our skin, our face, with wrinkling, our bones get thinner, but also women who smoke have an impacts by sort of killing off the ovaries, I should say ovarian function. So sometimes it's simple as getting people to stop smoking. We know the impact for drug use. That impacts the whole head, ovary problem, smoking, drug use, alcohol abuse, those kinds of things. Sometimes if you're too underweight, it impacts where you don't get a period. Anorexia, bulimia, eating disorders. So you can be too thin, which can make you not get periods. You can be overweight and not get periods regularly. So we kind of have to, it's
Find the
hard to
good
bundle
balance.
everything, but we have to sort of, if I see a person that weighs 80 pounds, I'm going to think differently about why she's not getting periods versus somebody that's 400 pounds.
Right.
And so as a doctor, it's really not a cookbook. We really try to individualize the care of the patient and look at each part of the woman to look at her in a whole way.
Sure. So when you talked about alcohol, I just want to ask you this question that came to mind. Some women drink wine during pregnancies. Some women are like, I can't touch alcohol during pregnancies or even during breastfeeding.
Right.
What's your take?
I think we should not drink any alcohol. It's deleterious. I mean, it's hard to say one drink.
Yeah.
Most women don't know that they're pregnant by a couple of weeks until they've had a missed period. But I'm talking about ongoing drinking. I think the human body is so fragile, and when we look at how we develop that, who's to say? And so I think avoidance during this time in your life is important. Yeah.
Great. And then, so I want to talk about 4 of the most common gynecological problems that women face. First one being endometriosis. So can we talk about what it is and if there are any causes?
Okay, so endometriosis, first of all, in medicine, for the most part, we don't know anything, okay? I mean, why do we get gray hair? Why do we wrinkle? Why do we sleep? I mean, so I just kind of, so there's a lot of theories, and when I'm speaking, in the public, I don't want to say this is dogma. So there are theories about why women may get endometriosis. One may be genetic, it just runs in families. Some people so what is endometriosis? Endometriosis is a condition where the menstrual blood, instead of it just being seen through the vagina and on our sanitary pads or tampons, the blood, one theory is that it goes refluxes. It retrogrades, blood goes backwards from the uterus, through the tubes, to the ovaries, and then to the peritoneal cavity, the organs, the bowel, the bladder that are there. There may be something that pushes the blood back. There may be structural problems. We don't know why, but it can be a condition that's common with no symptoms, but what would draw a patient to a doctor would be pain, usually.
Okay.
Bad menstrual cramps, missing work, missing school, having a significant pain with intercourse. Sometimes there's not a lot of symptoms, but the blood backs up and a doctor does an exam and can feel a large cyst on the ovary, and that's called an endometrioma, where blood accumulates by the ovary. And when we do surgery and there's a cyst that's like a little balloon and we open it, it looks just like Hershey's chocolate syrup, just old blood.
Yes.
Sometimes the blood continues on other organs. So what sits in front of the uterus, the bladder. Some women and behind it is the bowel. So some women may have very painful urination. We call that dysuria. Sometimes this blood, because it's inflammatory, kind of erodes through the bladder tissue. And some women, when they go to urinate, can see blood through the urine. Sometimes women have very bad pain. We call that tenesmus, bad pain with bowel movements, difficulty, aching, almost not wanting your stool to come out because the endometriosis leads to inflammation and scar tissue. Some women, because it can erode through the bowel mucosa, the surface, it can lead to blood in the stool. And so I would say the most common symptoms that bring a woman in, it could also lead to some change in menstrual cycles, but usually it's pain, and it may be potentially secondary infertility, meaning not being able to get pregnant. And, there's different degrees of endometriosis. We call it stage 1 to stage 4, minimal, mild, moderate, or severe. And certain things, very severe cases, if we here at the Cleveland Clinic use ultrasound and MRI very liberally, we may be able to see some of the evidence of scarring or cyst formation. The ovaries should kind of be like away from each other. Sometimes the scar tissue, we call them kissing lesions. The ovaries get stuck to each other because of the scar tissue. So there are different things that we might see on imaging, pockets of scar tissue, sometimes old accumulated blood in the peritoneal cavity. So it all depends on, the patient talks to the physician. Sometimes on examination, it even erodes into the vagina, where we can see these purple, bluish nodules that are there, or erode onto the cervix. So again, talking with our audience today, I would just say, see your physician if pain is a big issue, if there's some major discomfort with intercourse, and then let the doctor kind of go from there to work you through what test, what medications, if you need surgery, what type, because it's very individualized.
Right. So is there a cure for endometriosis?
Getting pregnant.
Getting pregnant.
Yes, it's a cure. So often
or birth control, right?
I was going to say the other is to stop menstruation. So one of the theories is just sort of incessant ovulation, having periods month after month after month. So women who've had kids, who breastfeed a long time, you're not getting a period, and they tend to not have these symptoms. Or just by not having a period, the body heals itself. I often think of if you were to look internally with a laparoscopy, it looks like an old bruise in there sometimes. And just like if you bruise your finger, that blood that's in if you smash your finger in, it doesn't drip out of your fingernail.
Right,
it gets absorbed, goes from black to blue to green to yellow, and it fades. So getting pregnant allows the endometriosis to sort of become dormant and sleeping. And so birth control pills and or other medications. We have a IUD that's progestin based. There's many different names, so I won't mention names, but a medicated IUD that could help also suppress symptoms until someone's ready to get pregnant.
So what I wanted to talk about was the insurance. So because infertility occurs in about 30 to 40% of women with endometriosis, does that mean insurance doesn't cover the condition if you're trying to get pregnant?
So, we have at the Cleveland Clinic over 500 insurers. So I would say we have to look individually.
Sure.
And sometimes doctors will code differently, meaning how they identify. So if you come in, sure, you're trying to get pregnant, but you have painful sex. You have very bad menstrual cycles. We might say, list the word dysmenorrhea, heavy periods, pelvic pain as a diagnosis without putting diagnosis of infertility front and center.
I see. Okay, and the next thing I wanted to talk about was an abnormal pap smear. So it should be done yearly, but what does
Not yearly anymore.
Yearly.
No.
Oh, what is it?
So it's now we usually would say you should get your first pap smear within 3 years of having intercourse.
Okay.
And then what we do are now usually by age 21 or whenever we start the paps, it's yearly to make sure that it's normal. But if you have all normal paps, it's gone to 5 years.
Oh, so once every 5 years.
If they've been all normal. And if you get to about age 65 and never had a problem with your pap, then we don't do it again.
Okay.
But again, these are guidelines.
Right.
So, everybody's different. So I would say, so we do pap, and now we know that one of the causes of precancer cancer is what's called the HPV virus, or human papilloma virus. So when we're doing paps, beginning at age 30, for women, once they're 30, we start doing co-testing, the traditional pap test coupled with the HPV virus. Okay. Because when we look backwards, even with slides and reference material from the 1900s that's here at the Cleveland Clinic, they didn't have testing for HPV. But when you pull those samples and now uses this testing, the women with cancer had HPV.
I see.
So we feel that cervical cancer is an STD, a sexually transmitted disease, because it's most commonly associated with the HPV virus.
Wow.
And we're now hoping that this next generation of physicians will not ever have to see cases, because we're recommending vaccinations for boys and girls
Yes.
and adolescents. Series, I won't go through everything, but you would go to the pediatrician and they would do a series of 3 vaccinations over time. And that nothing with vaccinations 100%, but it decreases the risk of precancerous cells and the subsequent development of cancer. That's something really hot off the presses in the last year, that our teens and preteens, it doesn't mean that this is going to make your 11-year-old or 13-year-old sexually active.
Right.
It is a method of prevention.
Sure, sure. That's excellent. So going back to the abnormal pap smear, what does an abnormal pap smear look like, and what are the next steps?
Most women with an abnormal pap smear don't know it, because it's even sometimes as a doctor looking grossly with our eyes, we don't see anything. It's the cells. We take a scraping of the cells, and then it's looked at under the microscope by our pathologist. And it just has an abnormal appearance. And then we do the co-testing with the HPV, and it often will be seen. And then from there, if the pap test is abnormal, depending on the type of abnormality, we may have the patient come back for a test called colposcopy. And it's just using a set of binoculars, and in the office we can look and magnify the cervix. There's something we put on the cervix that might highlight some abnormal cells, and then take biopsies of that. I don't know how much detail to go in, and then there's different treatments that are often office-based.
All right, and then we talked about uterine fibroids, and they are the most frequently diagnosed tumor of the female pelvis.
Benign tumor.
Benign. That was going to be my next question. So they're mostly benign,
Yes,
correct?
yeah. And I actually, what you said is correct. I really like to take out the word tumor, because when I don't tell a patient,
it's a scary
it sounds
word.
like cancer.
Yes.
So I just say you have a very common growth of the uterus, the muscle of the uterus, the 60 to 80% of women have, and let's see what symptoms you have, and then what are your reproductive choices, what symptoms can we treat in different ways.
They're benign, but do they increase a woman's chance of having uterine cancer?
No, because uterine cancer comes from the actual cells of menstruation.
Okay.
The fibroids are different. There's about 1 out of 350 women that have cancer within the fibroid. It's very, very rare. I've been here over 25 years. I've seen 3 patients in my practice, despite the thousands of women that have fibroids. So I'm not going to say it's never on my mind, but I don't want women hearing the word tumor and thinking cancer. Right.
Okay, great. And then lastly, abnormal uterine bleeding. So I know there's so many different things, but is there something that's most likely associated with abnormal vaginal bleeding?
We look at it at different life cycles. Let's first say, because I always want patients to learn from what I see, or all of us see. Once our periods stop, which is between ages 45 to 58, once we go 1 full year without a period, we should never see blood in the vagina or on our panties.
Okay.
It doesn't mean cancer, but I've had women who are 70 and start having what they call, quote, a period every other month, or they're bleeding. And some women said, oh, I'm getting younger. No, it doesn't mean you're going back to being 25. It is abnormal. A lot of women say, oh, it was just a little bit. Oh, I had no pain. Any bleeding should be evaluated. It turns out the number 1 cause of bleeding is that the tissue gets so dry and fragile, like parchment paper, and so thin that it bleeds. That's the number 1 cause. The 5th most common would be cancer. But between that dryness, it could be polyps, fibroids, precancer, infection, cervical problems. So if they see blood, the first thing is not cancer, but I don't want people to wait. If it is cancer, the symptom would then if you keep going on and on and on, it grows, invades into the muscle of the uterus, spreads outside the uterus, and then they have pain. So it turns out for uterine cancer, if you ask me, of all the cancers, GYN, if I had to choose one to have, it would be uterine cancer. Why? 85 to 90% have a symptom of bleeding. It gets worked up quickly, You have cancer, you get a simple hysterectomy. No chemo, no radiation.
Just get it.
It's done. But, I'm just saying, but when
Yeah,
people are
right.
waiting, and the other thing is a really abnormal discharge, feeling wet, moist, can also, so it can be brown blood, red blood, pink blood. It's just never normal. And
After menopause.
after menopause, and the doctor puts the speculum in, we look at the cervix. Bleeding could come from the cervix. There's vaginal cancers, very rare, but we look in the vagina when we have the speculum in.
Sure.
It could be endocervical cancer and just inside the cervix. It can be uterine. It can be ovarian. 3% of bleeding in women presents ovarian cancer. Presents. I mean, usually it's bloating, weight gain, or weight loss, urinary frequency, feeling nauseous, feeling full as soon as you eat. But 3% of ovarian cancers present with abnormal bleeding. So there's a whole host of things that doctors do to rule in and rule out what a patient has.
Sure.
And so I would say that's definitely. And then, as we mentioned earlier, changes in the cycle.
Right.
Too heavy, too long, many more clots, anemia, bleeding so much that you're tired, you're short of breath, you lose hair, you're craving ice, it's called pica, craving starch, craving dirt, unusual food cravings as a sign of profound anemia. That most commonly, if you're in the reproductive age, if you have anemia, where's the blood coming from? Usually it's from the uterus. It's not colon cancer. You're not vomiting up
Right.
blood.
Right.
So, we have to take a good menstrual history. So, that's the things that I would look at.
Sure. Now, can stress be the culprit of any of these issues that we talked about today?
I would say stress can lead to things like irregular periods if you're very, very stressed.
Right.
Everything from the pituitary gland kind of gets shut down. Sleep, your poor sleep hygiene.
You mentioned diet earlier.
And also stress as we are in the menopause can lead to more hot flashes and sweating.
Sure. And that's also imbalance in hormones can cause a lot of these issues?
Yes.
And that's also could be related to thyroid? Is that right?
Thyroid is always checked. Thyroid,
Okay.
we always
Okay.
check. About 1 out of 100 women have a problem, but that's an easy test. It's a cheap test. You'd hate to miss that.
Yes.
So, we just look for it.
Sure. Thank you. Well, that's all I have for today.
Excellent. Thank you.
you so much
Thank
for coming
you.
in today. Very, very informative.
Thank you.
And to make an appointment with a physician in the OBGYN and Women's Health Institute, you can call 216-444-6601. Thanks again to our listeners and viewers for joining us today. To listen to more of our Health Essentials podcast from Cleveland Clinic experts, make sure you go to clevelandclinic.org/HE podcast, or you can subscribe on iTunes. And for more health tips, news, and information from Cleveland Clinic, make sure you're following us on Facebook, Twitter, Snapchat, and Instagram at Cleveland Clinic, just one word. And we'll see you again next time.